Hello, everyone. I'm Jean Meserve, and thank you for joining us for this virtual event, The Equity of Cancer Care. With nearly 2 million new cancer diagnoses every year, cancer remains a leading cause of death in the United States. But women are less likely to die of cancer than men are. And the highest fatality rate of all per group is in African American men. Lung cancer, in particular, affects African American men disproportionately. And because of COVID-19, issues around disparities in pulmonary health have received particular focus and attention this year. Today, we will explore what the medical community is doing to improve the treatment of lung cancer and to improve lung health overall. We will also hear from experts working overall on disparities in cancer care and talk to them about what can be done to improve outcomes for all. A few notes before we begin. First, we'd love to have your participation. Please send us your questions. Use your chat on the right-hand side of your screen. Keep your questions short, keep them on topic, and let us know where you're watching from. We will get to them. Also, we want to say thank you to our sponsor, Amgen Oncology, for supporting the Atlantic's journalism and making this event today possible. For our first conversation on disparities in cancer care, let me introduce our guests. Dr. Brian Rivers is director of the Cancer Health Equity Institute at the Morehouse School of Medicine, and Dr. Nelson Aguila is deputy director of the National Cancer Institute's Center to Reduce Cancer Health Disparities. Thank you both for being here today. Dr. Aguila, I'd like to start with you. Numbers often tell the story, and I have a feeling they tell this story very well. What do the statistics tell us about equity in healthcare for cancer?
That's a very interesting question, and actually it's a very loaded question at the same time. And what is really happening during the last few years, there has been an improving in cancer survivability, and between 17 and 18 as was over 2% of people with cancer survive. However, this has not been reflected into the minority group, especially African American, who is the group that actually is more affected in terms of death rates and also is more at risk in every cancer, particularly lung cancer, like you said earlier, or prostate cancer for men and breast cancer for women. Also, multiple myeloma is a big issue in African American men. They are at a higher risk. So taken from it, and the cancer care, which involve cancer prevention, diagnosis, treatment, and survival, and there is disparities and inequities in every single part of it. There has been large advances, but this is not enough. And there are efforts in actually in producing more or improving these numbers, especially with majority groups within minority, which are African American and Hispanic.
Dr. Rivers, tell us what you think are the principal contributing factors to this disparity.
Sure, and thanks for having me. Very much glad to be a part of this conversation. So over 3 decades of research has showed us is that the reason why we're seeing these adverse outcomes in cancer is more so related to a multifactorial model, where it's not just one factor that's responsible for these adverse outcomes or these disparities, as we call them, but there's psychological factors, whether that's stress and mental health. There's social factors such as socioeconomic status or one's built environment that have been shown to be contributors to adverse outcomes, as well as environmental factors, behavioral factors, such as lifestyle factors, smoking behavior, physical activity, UV light exposure, screening rates. So what we're seeing is that there's multiple factors that have to be adequately addressed through a multi-level model to really get to the impact and the elimination of these disparities.
Dr. Rivers, I'm curious, you've listed a number of possible factors, and I know they all interact with one another. But is there one in particular that you think is more important than the others?
That's a very difficult question to answer. As a behavioral scientist, as a population scientist, I understand the breadth and depth of this problem. So, if we say the biological factors are extremely important, which they are, we have a lot of work to do in understanding the biological basis of cancer, especially among racial and ethnic populations. This pandemic just recently highlighted the role of social determinants of health and their adverse impact on health outcomes, and how many are projecting that the disparities that we're seeing in the context of cancer are being amplified. We also saw the role of chronic stress emerge, and we know that that has been a key factor as well as relates to cancer outcomes. And we saw it emerge again as a key issue in this most recent pandemic that we found ourselves in. And so to say one, if I had to establish some level of hierarchy, I think it will be a very challenging task to do.
Dr. Aguila, what about you? Do you assign a priority to one factor in particular?
No, actually, I agree with Dr. Rivers at this time, because the multifactorial events that happen for cancer health disparity, what it makes it so difficult to address it at once. One important factor also for health disparity is the lack of access or limited access to health care because of the lack of insurance or underinsured population. That actually is becoming, it has been a major factor as well. But in conjunction with what Dr. Rivers just said, everything, it becomes a very complex problem to just attack. And that is the reason that the responsibilities to end cancer health disparities is actually from private organizations, governments, institutions, and the community.
What about quality of care? Dr. Rivers, it seems to me that I have seen reports that have said that there aren't enough African American doctors, and that has an impact, and that sometimes African American patients are treated very differently by doctors who are not of their ethnicity. Do you believe that's a factor?
Oh, yeah, clearly. And just building on Dr. Aguilera's comments related to the clinical factors that are associated with adverse outcomes, we know at the patient level that there's, three principal drivers to a lot of the healthcare disparities that we're seeing, whether that's in the context of health literacy or low health literacy among racial and ethnic populations, or poor patient-provider communication has also been cited as a key factor to a lot of the adverse health outcomes that we're seeing. And then access and quality of care, realizing that there's substantial variability in terms of the quality of care one receives. There's numerous examples of multiple cancer types involving racial and ethnic populations that show forth the disparity that everyone's not receiving the standard of care, just to name a few.
And that quality of care could be impacted by economics, as mentioned, but also geography, right?
It could be. Definitely economics. We know financial toxicity is a key issue for many racial and ethnic populations that are being treated for cancer, but then also geographical proximity, whether one resides in an urban area or a rural area, their access to quality cancer care is impacted. And then, at the provider level, we're also starting to hear and learn more about implicit bias and the need for providers to undergo on a regular basis implicit bias training to ensure that the stereotypes and misconceptions that we all hold do not find their way in terms of the delivery of care.
Dr. Aguilar, I'm also wondering about issues of trust. We heard a lot about trust during the COVID pandemic, and that there tended to be distrust amongst certain populations. Do you believe that's a factor in care overall and in cancer care particularly?
Yes, definitely. That is a factor in care. And we have seen clear example. I think the example that it comes to mind all the time is the Tuskegee syphilis study. That is historical, very important, especially with African American community. I mean, it also just reemphasizing what Dr. Rivers said. There are several studies where it has been demonstrated that the physicians of the same, whether it's African American physician, Hispanic physician, or American Indian physician, the patients will trust more those physicians than somebody who is actually different to them. And actually, that has been demonstrated in several scientific publications. That is so important for us at the NCI that we have specific programs where we want to increase the number of not just researchers, but also physicians of colors and from minority institution and also minority groups, that it will be able to provide the services, the healthcare to these groups that are underrepresented. It is important to remind ourselves that this is something that it will take years. I've been working in this since 2001 when I joined NCI, and although the progress that we make is really one step at a time, but it doesn't mean that we are going to stop. I think we have the excellent possibilities right now with all the awareness that exists to end structural racism and implicit bias and increase the education in the physician that exists at this point in terms of to eliminate the implicit bias and provide better care to underrepresented minorities.
I'm wondering how implicit bias specifically impacts cancer care, and that you find that there are certain kinds of therapies or certain surgeries that are less likely to be administered to African American patients than to others. Is that the case, Dr. Aguilar?
Yeah, it is the case. I think there are several reports, especially with clinical trials. We always talk about that the underrepresentation of minority population in clinical trials at the cancer level. And one of the factors is that sometimes the physician do not tell the patient that there is a clinical trial available. That is one. Whether they do intentionally or not, that is actually debatable, but sometimes they may have comorbidities that the physician may assume, oh, this person is not going to be eligible for that clinical trial without giving any possibility. It is not that the minority population do not want to participate in clinical trial. There are enough evidence for that. It is the fact that there are clinical trials sometimes and they don't even know that they exist and they are not available to them. That is a part of an implicit bias. Sometimes there are also reports where some of the medication that exist or they are not the same, they are not used at the same level that they're used in other populations. And so those are the things that are important, that has been occurring for many years, and they need to stop.
Dr. Rivers, talk to us a little bit about that, if you can, that importance of having minority representation in clinical trials.
Well, yeah, it's extremely important. I totally agree with the sentiments that Dr. Aguilera just, remarked. It's extremely important. We're seeing study after study, talk about this notion of concordance, where the individual before me understands or look like me, and in that is a translation that they share a common value, a common belief system. And embedded in that is this element of trust, this element of safety. As Dr. Aguilera mentioned, there are several studies that have reported that African Americans and other racial and ethnic minorities are, no less willing to participate in clinical trials. But we're finding out that they're actually not being asked. And we understand that clinical setting is extremely important in terms of where individuals are being treated, one, and then what type of resources are available to various individuals. So if you're in an NCI designated cancer center, you expect high level care because the investment is there. But we know most minorities are treated, and some projections are around 85% of minority cancer patients are treated in community oncology sites. And so the question begs, how robust is their infrastructure, one, to deliver quality care to a diverse yet complicated clinical presentation that most minorities, often encounter the healthcare system with, but then two, how robust is the infrastructure to actually run clinical trials, which have so many different moving parts and that are highly complicated. And so setting does matter, and we have to foster strategies, that can overcome and transcend the limitations of various clinical settings to ensure all individuals are able to get that standard of care that they need.
Dr. Rivers, Tuskegee came up a moment ago. Henrietta Lacks come up. People say over and over again, there are good reasons why the African American community does not trust the medical community. In your view, how do we get over that issue?
So we have to start, at the ground level. There's been quite a bit of formative research completed over the past decade that really helped characterize some of the key drivers that is eroding trust, not just among trust with the provider, but even trust with researchers and trust with healthcare settings. So we must begin to target these initiatives, very strategically. I know the National Cancer Institute has some signature programs, that are really decentralizing a lot of these activities, especially the information and education component. We saw the role of education really emerge during the pandemic, where individuals were looking for information, salient, relevant information, trustworthy information, but being that the clinical setting where they usually got most of the information from was so saturated or overly inundated, dealing and addressing issues around COVID, that a lot of information gaps has really emerged and they were pronounced, and it just, again, eroded the fabric of the research enterprise as well as the clinical enterprise. And so, again, we must begin to think about strategies that help build trust, that are outside of the clinical setting, that individuals can turn to and receive a message that they can trust and believe in. And again, I think the pandemic gave us some key lessons and some key takeaways for us to really bring into cancer.
We have gotten some audience questions. Let me pose a couple of those to you. One viewer asked, we've learned that implicit bias training is woefully ineffective. What are some other approaches to combating this bias? Which one of you would like to field that?
Let me start with that. I think the implicit bias is a needed training, and actually it is. I think people sometimes confuse implicit bias. For me, is an education aspect that is really important, because sometimes we all have some kind of implicit bias and we don't realize until we are not being told so. And I think it becoming a very important tool. And how effective it's going to be, it is not just the responsibility of having an implicit bias training, but it's our responsibility as individuals to actually follow through with that and actually and put it in practice what we learn.
Sure.
We also have a question from Jacob, who asked, given the opportunity to target the training of healthcare workers, what would you change about their training? Dr. Rivers, do you want to handle that?
Sure. That the training would not be cross-sectional, meaning it would just happen, at one point in time over the course of a year, but there will be ongoing trainings. And again, the strategy is not to learn all you can about everyone's culture, but it's to recognize your own limitations or your own, misconceptions, stereotypes, and biases, and just make sure that they're not influencing how you're administering or delivering care.
Dr. Rivers, you're working with the National Cancer Institute on a clinical trial of mobile technologies that would be accessible to African American men with prostate cancer. Tell us a little bit about that and what you're trying to get at with that particular device and experiment.
Sure, yeah. So it's a randomized controlled trial that we actually received funding for through an R1 mechanism. That we're really looking at the sequelae of events that really diminish quality of life for most African American prostate cancer patients. It's a very confusing, daunting process for many men as they go along their prostate cancer journey. And there's still a lot of gaps in terms of the shared decision-making process, especially around treatment for localized disease. And so what we did was we came up with a novel, what we feel is novel, innovative, integrated model that utilizes the patient navigation model coupled with a standardizing agent of mobile technology that really addresses the psychosocial burden as well as the psychosocial functioning that often accompanies one across their cancer journey. And so we're actually in year 5 of this study. So we don't have data yet, but we're extremely excited about just this new model that it could potentially introduce, because what it's doing is decentralizing a lot of key activities that historically has taken place in a healthcare setting, and it's putting it in the actually lap of patients, and then they can share with their elements of social support, which research has shown, and some of our studies have shown as well, is extremely important to help men, understand what is happening to them, and also again address the psychosocial burden that often accompanies a diagnosis of prostate cancer. And we know that many of the side effects for prostate cancer can be severely debilitating. from the physical side effects of impotence and incontinence to the social side effects that really dampens individuals' enthusiasm about engaging with others in their social network, to the stress associated with managing this new disease. And so again, we're after issues around quality of life as well as dimensions of quality of life through this initiative. So we're extremely appreciative for the NIH award, and we're extremely excited about being able to just study this approach. And hopefully preliminary data will let us know if it's something that we should actually expand.
So two questions. One, when will you have that data? And two, if this works, this would be applicable, I presume, to other kinds of cancer, correct?
Oh, definitely so. And so, within hopefully over the course of the next year, we will begin analyzing the data more robustly, publishing our findings, as well as presenting them nationally at scientific meetings. And it will, again, based on the preliminary findings, it will inform if we actually scale this intervention and expand it to other disease sites. Now, the patient navigator model isn't new. It was established by Harold Freeman, to help resolve why African American women diagnosed with breast cancer, were returning at a much, much later time than desired for treatment. And it helped resolve and shrunk the time that African Americans that were diagnosed with breast cancer showed up for their initial course of treatment. And so we're applying this navigation model in the context of prostate cancer, but then we have this standardizing agent to ensure that evidence-based information is communicated to patients, and there's no compromise in the integrity of the health messaging that they will otherwise get from their healthcare provider.
Dr. Aguilar, we have another question from the audience. This viewer asked, given that disparities are multifactorial, what recommendations do you have for health systems, pharma manufacturers, and insurers to work with other sectors, for instance, housing, food, city planning, etc.?
Oh, that is actually a very, very interesting question, and it's a whole topic for a new forum. But what the NCI is doing in order to address is we're trying to establish partnerships. And initially, we start with partnership between two different institutions in order to increase or to improve cancer health equity or to ameliorate cancer inequalities. So one of the things that is very important is for the government to establish partnerships with the pharma, which is NCI has many, and also not just NCI, but different federal agencies at the same time that they have same purpose to establish also as well partnerships with pharma, but not also just with pharma or other institutions, but also integrate the community into it. I think one of the things that we have learned throughout the years, especially with community-based participatory research, it was that researchers we used to imagine that this is what the best for the community without consulting. And now with CBPI, it is actually incredibly important to engage the community from the beginning because they know what they need. And that is very important to design any plan or any project that we can actually do, or any strategy that we want to develop in order to ameliorate cancer health disparities. The community will have to be involved as well.
So it's not exactly a newsflash that there are disparities in cancer care. We've known this for years. Efforts have been made. Let me ask you, as we're drawing to a close here, if we're seeing progress. Dr. Aguilar, let me start with you. Are we seeing some improvement?
Yes, definitely. We have seen improvements throughout the years. Let's consider that 35 years ago there was the Heckler report, which was the first time that it was a very extensive studies about the disparities that exist in African American and other minorities. From there until now, there has been palpable improvements, but there's so much to do still. So one of the major improvements is actually it was like the Affordable Care Act and the Medicaid expansion, and that is, I think, it's it's produce an amelioration or diminishing of the access to care or to healthcare. The other thing is NCI were very important in increasing the participation of minority in clinical trials. And there is a law, I think, that there was approved by Congress, the Clinical Trial Act, that it will be starting January 1, 2022, and will allow Medicaid-served patients to be able to be paid or reimbursed by the when they participate in clinical trials. So that is incredibly important. So those are progresses, but we can really not stop. This is a continuous fight, and we are here for the long run.
Dr. Rivers, we're out of time, but very quickly, reason for hope from your perspective? Oh, I'm sorry. He seems to have frozen for the moment here. You're back.
Okay.
Dr. Rivers, quickly.
Yes.
Very quickly. Reason for hope. Are you optimistic at this point in time?
I'm very optimistic. I'm looking at the dynamic nature of the field. We have more transdisciplinary as well as multidisciplinary teams in the field of cancer, as suggested by the decreasing mortality rate for all populations in this country. We are making progress, but we still have much more work to do. Very encouraged also by the National Cancer Institute, Center to Reduce Cancer Health Disparities. They have a key initiative called PATCHI, Partnerships to Advance Cancer Health Equity. And so initiatives like these will ensure that everyone's at the table, that we're in increasing minority enrollment in clinical trials, we're advancing workforce diversity, and we're advancing our biological understanding of cancer itself. So I'm extremely optimistic that we will see an elimination of these disparities very soon.
And we'll wrap it up there. Brian Rivers and Nelson Aguilar, thank you both for joining us here today. I appreciate it. And now for a word from our underwriter, Amgen Oncology. Please welcome Ai-Pen Chang, Vice President and Therapeutic Head for Oncology Global Medical at Amgen. David M. Waterhouse, Co-Chair of the Department of OHC Clinical Research. Juanita Segura, a lung cancer patient and advocate. And Jean Regnante, Chief Health Equity and Diversity Officer at the Longevity Foundation.
Welcome. I'm Ai-Pen Chang, Vice President and Therapeutic Head of Oncology Medical at Amgen. It's really a pleasure to be here today to address the importance of health equity as it relates to biomarker testing and access for patients with lung cancer. Over the last few years, we've really seen an evolution and a shift towards precision or personalized medicine in many cancer. While tremendous strides have been made in understanding the biology and also identifying novel targets for drug development, there's still ample opportunities to improve outcomes for patients with difficult to treat cancer, such as lung cancer, which unfortunately still remains a leading cause of cancer death worldwide. Biomarker testing includes identifying genes, proteins, and other markers that can provide additional insights into a patient's specific cancer. More importantly, these results can be utilized to develop a patient's personalized treatment approaches, as well as track outcomes to treatment. While there's been an increase in awareness for biomarker testing over time, we still see a big gap in terms of patients' understanding and, more importantly, access to these important tests. This is the reason why we're here today. I'm pleased to be joined by a great panel today: Juanita Segura, Dr. David Waterhouse, and Jeannie Regnante. Welcome, and thank you for joining me today. Juanita, let me start with you. I know biomarker testing has played a very important role in both your diagnosis and throughout your treatment journey. Can you share a little bit about your experience and how knowing your biomarker status has really impacted your treatment plan?
So I was diagnosed in 2014, and well, it was devastating for my family and I and my husband. And I couldn't really do research because I was so depressed and so sad. So my husband did it. He went on Google and researched everything under the sun and came up with biomarker testing. So when we went to the cancer center where I was having my treatments, he brought up the biomarker testing and they were very aware of it. So I had to have a few bronchoscopies to get enough tissue to find out, if I had a gene mutation, which they did successfully. And the last day of my chemo radiation is when I found out that I was ALK positive. And I'll never forget, my husband started crying. And I told him, why are you crying? He goes, you could have avoided chemo radiation. You could have went straight into targeted therapy. He goes, I feel like I failed you. I feel like, I should have fought more, pushed more. After chemo radiation, I got on targeted therapy and I've been living and thriving ever since. It changed my life. I push and push and push biomarker testing. I think it's so important.
Juanita, thank you so much for your story. You're an inspiration to all of us.
Thank you.
Dr. Waterhouse, thank you. Dr. Waterhouse, welcome to the panel. We know that the utility of biomarker testing to guide treatment selection has really improved the survival and the quality of life of many cancer patients. Yet despite this, we also know that not all patients are tested according to guideline recommendations. Why do you think this is happening?
Well, you hear the story that we just heard and you're so inspired and you know that there's a great need for these biomarkers to be tested. But you're right. We know that not every patient is being tested right now, and yet they need to be. We can't be pretty good at this. We got to be excellent at it. We have to test everybody to make sure that the right patient gets the right treatment at the right time. We know that almost 90% of patients will have at least one biomarker tested, but there's more than one. And the current recommendations are for next-gen sequencing. And yet real-world data is now telling us that probably only half of our patients are getting that done. And again, turnaround time remains problematic.
Dr. Waterhouse, I know that this is a topic that's very close to your heart. What can we do to improve access to biomarker testing in the community setting where we see that over 80% of cancer patients receive their treatment, yet statistics have shown us the testing rates are lower in a community setting?
So I think there's several things. The first is provider awareness. The doc has to order it. So making sure that every doc knows that every patient needs to be testing. The second thing is we need to make sure that every patient can get that access. So we don't want to see insurance barriers or lack of insurance or underinsurance become a barrier. In this country, we shouldn't have those kind of financial barriers to getting the best care. This is a team effort. It's not going to happen unless we all decide to work together and pull together. We need more patients just like Juanita. That's why I wake up in the morning.
Thank you, Dr. Waterhouse. Greatly appreciate your perspective. Jimmy, let me go to you next. Longevity Foundation has been leading quite a bit of research in this particular area. From your perspective, what are some of the barriers to biomarker testing within the underserved population?
We at the Longevity Foundation like to refer to opportunity populations as opposed to underserved populations because, quite frankly, we have so many opportunities to learn from them and work with them so they are empowered to get better access.
So Jeannie, based on your research, are there any short or long-term solutions that we could deploy to address these issues?
We believe that all lung cancer patients should ask their doctor if comprehensive biomarker testing is right for them. We recently launched a multi-year national campaign called No One Missed. And the No One Missed campaign will introduce tools to empower all lung cancer patients and caregivers to request comprehensive biomarker testing from their healthcare team at the time of diagnosis. From an educational perspective, we are taking a validated health literacy approach to patient education with many communities. And what we have learned is that through our research is that multiple stakeholders agree that patient educational materials for biomarker testing should include why testing is important, who should get tested, and when, at what point in their treatment journey should a patient get tested. And advocacy, this is a really important area. And we're really focused on the important and hard policy work at a state level, focused on Medicaid coverage to really ensure that there's equitable access to comprehensive biomarker testing for all.
Well, this has been a great discussion. I want to thank all of you for joining me today to address this important topic of health equity as it relates to biomarker testing. As part of our mission to serve patients at Amgen, we are committed to advancing solutions through partnerships and initiatives with the goal of raising awareness and supporting broad and easy access to comprehensive biomarker testing for cancer patients. Thank you once again for joining us.
And now a discussion of pulmonary health, which has been very much on our minds during the COVID-19 pandemic. And it's another area where we see racial disparity in treatment and outcome. Let me introduce our guest, please. Harold Wimmer is National President and Chief Executive Officer of the American Lung Association, and Janelle Gray is Program Co-Leader and Molecular Medicine Chair in the Department of Thoracic Oncology at the Moffitt Cancer Center. Great to have you both with us here today. Harold Wimmer, COVID clearly is one of the threats to lung health, but what are the others that we're facing today?
There's a number of threats that we are facing today, not only including COVID-19, as you said, but also as we look at other types of lung disease, such as lung cancer, chronic obstructive pulmonary disease, idiopathic pulmonary fibrosis. There's more than 40 different types of lung disease that the American Lung Association is really focusing in on. But it's not only the lung disease, but it's also the risk factors that tie into what causes lung disease. And of course, one of those is in terms of air quality, which is also a key factor in terms of lung disease. But COVID-19 has certainly laid bare the health inequities that many Americans are facing, including our Black and Brown communities. So, we have really learned a great deal through the COVID pandemic, and in ways that we need to address some certain key health aspects to better control lung disease.
Dr. Gray, again, let me ask about numbers. What story do they tell us about disparities?
So these numbers tell us and draw our attention, as you heard from the prior speakers, and raise the alert on that we have high levels of disparities in our Black and Brown communities, and that we need to come together as a whole community in order to reduce these disparities. I agree with the prior speakers and prior moderators and the prior panelists that we really need to put our efforts together and get education out there, both to the patients as well as to the providers. I really resonated when I heard that session on implicit bias and having your own internal checks, especially as a provider who delivers healthcare. We all need to take that pause. We need to recognize what we need to do for each patient, and particularly focusing on that patient that is sitting in front of us and making sure that we give them the attention that they need so we can deliver the best care possible.
Now, lung cancer seems to afflict African American men in particular. What do the numbers tell us, and why is that the case?
Yeah, so really great question. So a couple of things that we found when we take deeper dives into lung cancer. Lung cancer first is the second most common cause of cancer across men and women. It unfortunately causes more cancer deaths than breast, prostate, and colon cancer combined. The mortality rate for this cancer can be very high. When we start looking at the Black community in particular, some of the things that we find, one is that the doses of tobacco exposure in this community tend to be lower despite the risk of being diagnosed with lung cancer. The other thing that we see is exactly what you allude to, that Black males in particular, their mortality rates are higher. So this is likely due to multifactorial areas, but we need to look into all of these. One is looking at biological variants. Is there something within the Black community that is different? We need to look at access also. There's been lots of studies within this area, and one of the things that has been found is that there can be delays in presentation for lung cancer. That means that a lot of these patients are presenting, unfortunately, at later stages, which have worse outcomes. The other thing that we need to think about when we look at this community is the smoking and the type of cigarettes that is being utilized and has been advertised in this community. And I know we'll be talking a little bit more about that, but those are just some of the reasons why we think we're seeing the findings that we have here.
Mr. Wimmer, do you want to weigh in there? Why do you think we're seeing these disparities? What's your analysis of the situation?
Well, I mean, we're really seeing in terms of the smoking risk factors that tie closely to the increased numbers that we're seeing among Black men. Also, in terms of, as Janelle mentioned, in terms of access to healthcare, which is so important. And what we're also seeing is in terms of early detection for lung cancer. I mean, that's really key, is in terms of the prevention part, the early detection, and then also helping to assure that lung cancer patients have access to affordable and quality health care, which is so important.
Dr. Gray, we heard a lot during COVID about how people were delaying screening. And so diagnosis was happening later rather than earlier. Have you really seen this have an impact when it comes to lung cancer in particular?
Yeah, so we have some great data that's come out initially within the breast cancer and the colorectal cancer research, and that really helped to raise the alert that we need to do more as far as educating the providers in the community. That lung cancer screening should be something that is discussed as part of your primary health care, and that you're educating the primary health care physicians as well as the pulmonologists who see these patients to refer them over. One of the things that has happened recently under the guidance of the U.S. Prevention Services Task Force is the guidelines for who qualifies for lung cancer screening has changed to make it more broad and to make it more intentionally inclusive. So currently, if you are at the age of 50 or over, or you have what's called a 20 pack year history of smoking, your pack years helps to quantify your lifetime exposure to smoking. And they've lowered this now from 30 pack years down to 20 pack years, that now makes you qualify for lung cancer screening. And so we hope with these efforts that we can reach a broader community. And I couldn't agree more that early detection is critical. Do not delay seeing your doctor if you have any symptoms or if you meet these criteria. It's really important, despite the pandemic, to come in and get the health care that you need.
I'd like to ask you both this question. COVID certainly has had an extraordinarily negative effect, taken a lot of lives, but has it also taught us anything, particularly when it comes to pulmonary health? Mr. Wimmer, you want to take that first, please?
I mean, it has certainly taught us in terms of the importance of being public health ready, is to assure that we do have systems in place. I think that we saw that from day one of the COVID pandemic, is that we need to have a strong public health infrastructure that is ready to test and to be able to provide treatments for those that are diagnosed with COVID or other lung diseases. I think it's really come down to learning that we need to be prepared. And, that's something that we are certainly working with our partners on.
Dr. Gray, from your perspective, anything learned from COVID that could help lead to better pulmonary health and might reduce disparities?
Yeah, I think that's a great question. So we have, I know at Moffitt Cancer Center, we've certainly learned a lot. I agree again that, being agile and nimble within your healthcare system to address the needs of your patient population is very, very important. It is also very important within the lung cancer community that we take advantage of what's available to us, i.e., that multidisciplinary care. We have strengthened our partnerships with our pulmonologists in particular and our radiologists when patients come in with symptoms, really understanding and dissecting what is the root cause of the symptom. Do we think these is related to COVID? If we have abnormalities in the lung, do we think they're at risk for developing or have a potential lung cancer? Could this be a patient who's having a COPD exacerbation? And that teaching us that we must all sit at the table, hear each other, and learn from each other. I absolutely think that is something that we have learned and will carry on for generations to come. When it comes to disparities within COVID, I think it's really unmasked and brought back to the forefront that mistrust within the Black community, in particular as it comes to moving agents forward and rapidly into the field. And I think it gives us a sense that we need to take pause. We need to think and reflect about why that is, respect why that is, and then develop next steps about how do we move forward from here all together.
So I asked the previous panel for their thoughts on how to overcome those attitudes. Let me quickly ask you, do you have any solutions to this attitudinal problem?
Yeah, I think that we need to, again, it's focusing, it's first looking at yourself as a provider. All providers have to do this. I know we've all gone through implicit bias training, include here at Moffitt. We've taken multiple courses on it. Having also, I think, creating a forum by which we can have courageous conversations where people can share their experiences within your work community. I think that also raises the importance of this topic and then allows you as a provider, I think, to better relate. One of the things I also strongly encourage my colleagues is to just recognize that you need to take that pause. When you're in the room with the patient, there's a lot that we all need to get done. We need to document, we need to get our dictations done, the other patients waiting in the room, but making sure that we make patients feel comfortable. It also can take time to build that trust. And the other thing we can think about that I think may improve things is why don't we just ask the patients, what do they think? What do they see as the barriers? Do panels like this that are not just with providers, but are also with patients and hear from them. And then take that and let's move forward from there. You develop tools from what we hear that can be deployed diffusely as well as that can remain as something that we consider would be sustainable. Great question.
We have a question. We have a question from Aaron. Aaron says, too many patients become financially impaired during cancer treatment, and the ability to find a clinical trial is impaired as well. Is there any data suggesting that white and non-white patient outcomes differ in impoverished communities and individuals? I think the answer is yes, but you're the experts.
Yeah.
Mr. Wimmer, thoughts on that?
Well, there certainly are health inequities there. And it also comes down to attaining affordable and quality health care. Also in terms of insurance, if populations have insurance, I mean, here in the United States, still 30 million Americans are uninsured. Half of those are Black Americans. So they're facing real challenges, and to be able to afford health care is certainly key and part of this.
Mr. Wimmer, you mentioned flavored cigarettes earlier. The Biden administration has made a proposal to remove menthol and other flavors from cigarettes in the marketplace. Do you think that's going to have a significant impact if indeed it's successful?
It will have a giant impact. It's probably one of the
that was forceful.
Recent...
Why do you say a giant impact?
I mean, if you think about it, just in terms of health disparities, with our Black Americans who are smokers, 85% of them smoke menthol cigarettes. So the tobacco industry has really been targeting Black Americans, brown Americans, to get addicted to tobacco. And to be able to remove menthol cigarettes from the marketplace is going to be a very significant public health step. And we believe it will certainly reduce lung disease incidence just by that step alone. So it's going to be a tough battle. I mean, we certainly applaud President Biden and his administration, and we know that there's a lot of work that the FDA has to be doing. But we also know that the tobacco industry is going to put up a big fight on this. And so from an advocacy front, we really need to make sure that we are getting the right public health information out there around this very important decision here. So.
Dr. Gray, do you agree that the removal of menthol cigarettes would have a significant impact on the disparity in lung health?
Yeah, I think that it is a very important move again by the Biden administration. The smoking, number one risk factor for lung cancer is smoking. About 80% of males who have lung cancer, 90% of males who have lung cancer have a history of smoking, and 80% of females who have lung cancer have a history of smoking. Anything we can do to reduce the level of smoking within the community can have a big impact. We know that lung cancer rates have decreased over time. One of the main drivers is that has been the decrease in the smoking rates over time. We also know that within smoking, that when we look at it, that we need to target and reach our youth population and stop them not only from smoking, but also to get them to not start. And I think removing these cigarettes off the shelf is a great move and an absolute move in the right direction. When you look at the recent report that has been put out there about cancer rates and cancer death rates, that there has been a big drop in the last couple of years. We've made substantial improvements, and one of the number one drivers of that is lung cancer. So anything we can do from smoking, which then leads to lung cancer, would lead to even better impact more broadly across the field. So absolutely agree with the move and happy to work in any way to get that initiative moving forward.
Dr. Gray, you also have been doing some work on immunotherapy and drug combinations to fight drug cancer. Tell us in layman's terms, if you would, what that research involves and whether you think that would help address the disparity when it comes to lung cancer.
Yes. So immunotherapy is one of the agents that has really been at the forefront for patients being diagnosed with multiple cancers, including lung cancer. This has really been a game changer for many of our patients. We certainly want to do the molecular, that biomarker testing that you heard about earlier from our patient advocate. That is critical. And it is really about that precision oncology, matching the patient to the right therapy at the right time. And many times that can be a potential targeted therapy. And a lot of times it can also be an immunotherapy. I think a lot of us saw this on the front pages of big magazines and the movement in that area. These drugs are now approved for our patients, and anything we can do to combine these with other agents in the future, such as what we're doing here at Moffitt, along with my own research, is going to help, I think, to improve outcomes for our patients even further. Really critical. We just want to move the bar and continue to drive those diagnosis rates down, as well as drive the mortality from this cancer down.
Mr. Rimmer, lay out a roadmap for us. What things still have to be done to address pulmonary health, but also even more critically to address the disparities in pulmonary health?
Well, there's a number of steps that we still need to be working on together, and that includes helping to assure that everyone has access to quality healthcare. Affordable quality healthcare is really important, and that everyone has access to preventative services, which is also key to this, And, as we talked about in terms of lung cancer, screening, early detection is also essential as we look at ways to really address lung diseases across the spectrum. So it's really making sure that there's affordable health care for everyone. And that's something that the American Lung Association is working on as an organization.
And Dr. Gray, quickly, the medical community itself, what's the number one thing it could do, should do to improve outcomes?
I think screening is absolutely something that we should focus on as a whole community within the setting of building awareness about referring patients to screening in a timely fashion. That if we can get screening going, that leads to the prevention, that leads to the early detection also. I think that is hugely critical and a big initiative. If we look at other cancers such as colorectal cancer, look at breast cancer, cervical cancer, and look at their screening rates, we have a long way to go. Right now, when we look at the numbers, only 5% of the population that is eligible for lung cancer screening actually undergoes lung cancer screening. We have to do better.
Janelle Gray, Harold Wimmer, thank you both for joining us today. Thank you to all of our guests for joining us. We've enjoyed the conversation and learned from it. And I also want to thank all of you out there who joined us online. We'd love to get your feedback. We hope that this was a valuable experience for you, but we want to learn more. So if you would, you will get a survey that you can access through your chat, or you'll get a copy of it in your email. If you could respond to that, complete that, that will help us shape our future programs at The Atlantic. Please visit theatlantic.com/live to get a rundown of some of our upcoming events, including our Health Equity Summit that's coming up on June 22nd. And if you are not already a subscriber to The Atlantic, you certainly should be. Thank you also to our underwriter, Amgen Oncology, for making today's program possible. Thanks a lot for watching. I'm Jean Meserve. We'll see you next time.